Hi everyone. Hi. Hi, my name is Jaywin. Before the presentation starts, please allow me to introduce ourselves. My name is Jaywin, and my teammates are Winnie, Juan Lee, Wei, and Xiaohui. Okay, today we are going to present case 4, which is a case about a 60-year-old hypertensive patient who did a stenting on the left anterior descending artery 8 years ago. And now, restenosis occurred on the respective artery, and the doctor suggests him to perform a coronary artery bypass. In this presentation, we are going to talk on anatomy of coronary circulation, some common abnormality, and some pathophysiology regarding to the LAD, and also some surgical and clinical measures regarding to the scenario. So without further delay, let's move on to anatomy of coronary circulation. First, we look at the coronary artery and its branches. Basically, coronary artery is divided into two, the left coronary artery and also the right coronary artery. And here are the list of the branches. Yeah, no worry, although it seems very complicated, but I'm expecting you to remember a few branches only. For the right coronary artery, please just remember they are SA node, AV node are supplied by right coronary artery. And the most important branch in right coronary artery will be the right marginal branch and also the right posterior descending artery, or we call right interventricular artery. But for the left coronary artery, only two main branches you have to remember in this session will be the circumflex branch and also the left anterior descending artery, LAD, or we call it also as left interventricular artery. Okay, now we are going to learn more about this artery and the branch by watching a video. Okay. Maximum volume. Sorry, the audio? IT support, please. Okay, I'm the IT guy in my batch, so okay. So I have to settle myself, no worry. Is the time pause? Okay, let's watch video. This is made by me and my friends. Hello? Technical support. Don't worry. Let's see. I hope it works. In this video, I will. Okay, this is my voice. In this video, I will show you the branch of left and right coronary artery. First, we will go to right coronary artery. The right coronary artery originates from the right aortic sinus of the ascending trunk. As it travels right down towards the heart, the first branch that goes towards the pulmonary trunk is the coronary artery. As it travels along to the inferior border of the heart, this branch is called the marginal branch. And when it goes to the posterior part of the heart, it supplies the posterior interventricular branch. Let's move on to the left coronary artery. After it branches out from the left aortic sinus of ascending aorta, it will give off to two main branches. The one that travels down at the anterior part of the heart is called the anterior descending artery, or we call it left anterior interventricular artery. The other branch that goes to the posterior part of the heart is called circumflex artery, and it branches the marginal branch at the border of the heart. Thank you. Okay, next we are going to learn what are the areas supplied by the arteries. Okay, back. Area supplied by the artery. Okay, here is the right coronary artery. So what is this structure? audience, this is the right atrium, and here is the right ventricle. So we can say that right coronary artery gives supplies to right atrium and right ventricle. And at the posterior part, we can see this is the right interventricular artery, and it supplies the posterior 1/3 of the right interventricular septum. And as you can see, there's some branch towards the left atrium. So is right coronary artery also supply blood to minor parts of right atrium. And bear in mind, as you can see here, there's a branch towards the SA node. So this is called the sinoatrial nodal branch. It gives supplies to SA node and also anteroventricular node. The branch is here. And for the left coronary artery, this is the main and most important artery. This is the LAD artery. It is very important because it supplies anterior 2/3 of the interventricular septum and also your heavy bundle. So if any abnormality occurs here on this LAD, your life is in a very dangerous situation because your heart cannot get the contraction, not enough blood to pump. And then for information, 50% of the myocardial infarctions is caused by this LAD. So now we are going to learn the vein. Since the case is not emphasized on vein, so I will just brief through. The vein, the most important thing is the coronary sinus, because it drains 60% of the venous return via a few main branches, or we call it tributaries. The first one is the great cardiac vein at the anterior of the heart, posterior, middle cardiac vein, and small cardiac vein. No worry, we will watch a video again. Okay. In this video, I will show you the coronary sinus and its 4 major tributaries. This is the posterior view of the heart, and this thing here is called coronary sinus. The first branch of it is at the anterior view of the heart that associates with the left anterior descending artery. This is called the great cardiac vein. As the posterior side, this is called the posterior cardiac vein. The third branch is associated with the posterior interventricular artery. This is called the middle cardiac vein. And the last major tributaries that associate with the right coronary artery and travel along to the right marginal border. This is called the small cardiac vein. Okay, everyone, do you understand a bit? Okay, now I will pass my mic to my friends.
Okay, I will now talk about coronary in-stent restenosis. Coronary in-stent restenosis basically is the re-narrowing of the previously stented blood vessel in the angioplasty procedure. As you can see here, normally after a successful procedure after 3 to 12 months, restenosis or stent thrombosis can occur. It can present itself as a recurrent angina. It also can present itself as acute MI in 10% of patients. How it occurs as recurrent angina? As the LAD is narrow, the myocardium with responsible for the contraction will be affected as it not get enough blood supply. So this causing it to have lack of oxygen supply, causing ischemia. I will now talk about the pathogenesis. Angioplasty can cause vascular damage and also rupturing of atheroма. This will cause the activation of inflammatory mechanism, which consists of thrombogenic, vasoactive, and lymphocyte mitogenic factors. This activation will cause neointimal proliferation, which is smooth muscle hyperplasia, and also cause formation of thrombi by the rupturing of atheroma. Because the stent that is placed in the left anterior descending artery, it can pierce through the atheroma and might cause a rupture into it, and this will cause thrombi formation. Okay, as you can see from this picture, the first picture below, this is the first time it undergo angioplasty, and after a while, as you can see over here, the smooth muscle proliferation in the tunica media has proliferated partially, covering the stent, and as you can see here, it re-narrow again. This causes restenosis. Okay, now I will talk about heart failure. Heart failure is basically the condition in which heart could not pump sufficient oxygen-rich blood throughout the body according to demand. It can be separated into two categories, which is reduced ejection fraction or preserved ejection fraction. Reduced ejection fraction will cause the reduction in cardiac output, stroke volume, and also heart rate. Ejection fraction basically is the volume of the fraction of blood ejected out from the ventricle in the stroke volume. Okay, I'll talk about the pathophysiology of heart failure. As the LAD artery is stenosed, this will cause a reduced blood flow to the myocardium, and this will cause ischemia. Like I said just now, this might cause angina pectoris, which also can cause MI. And compensatory mechanism, such as Frank-Starling mechanism, which the muscle length will increase, will stretch to increase the contraction further. The activation of neurohumoral systems such as renin-angiotensin system and ventricular hypertrophy. And in long duration, if the compensatory mechanism fail, this will cause cardiac failure. I will now pass to my friend to explain the management.
Okay, I'll try to intervene here. Okay, we expect the groups to stick to the concept. You know, the concept has been explained and the information was sent to various groups. You have to stick to your, let us say this, they're supposed to just explain coronary circulation and its applied aspects, but not explain the pathophysiology of cardiac failure or management and all. Okay, so I think the group has already presented, so that's, okay, you want to summarize?
Yeah. Lastly, let's just watch a video about angioplasty. It will take around 1 minute and 43 seconds. Thank you.
Your heart receives oxygen and nutrients from blood flowing through your coronary arteries. Fatty deposits, called atherosclerotic plaque, can build up inside these arteries, narrowing the passageway and interfering with blood flow to your heart muscle. Instead of surgery, your doctor may perform less invasive procedures, such as percutaneous transluminal coronary angioplasty, or PTCA, and stenting to open narrowed arteries. Over 70% of coronary angioplasties include stenting. During these procedures, your doctor will insert a sheath or soft plastic tube into a large artery in your groin. Next, your doctor will guide a flexible wire through the sheath and gently up through your circulatory system into your narrowed coronary artery. Then your doctor will thread a balloon-tipped catheter encircled by a balloon expandable stent over the guide wire, gently advancing the catheter to the narrowed part of the artery. By inflating the balloon, your doctor will gently push against the plaque, compressing it against the vessel wall. The inflated balloon will then expand and lock the stent in place, keeping the artery open and improving blood flow after the catheter is removed.
So now is Q&A session.
Okay.
Audience, any questions to ask?
I have a question.
Okay.
Is it okay if I talk like this? Can you guys hear me?
Okay, you can tell your question, so we'll repeat it.
Okay. All right. Thank you. Okay. Hi, my name is Julian from Perdana University. I have a question here. So, should medicated stent, like for example, antithrombotic agent, should be applied in every patient, especially in this case? Do you think that it's wise to do so? And what are the situations where you don't need such therapy or medication? Thank you.
You mean anti-thrombotic agent before the surgery?
No, put along with the stent.
Because according to my research, it's done by some of the doctors. Like the stenting, they will put a layer of medicine. It's done by some doctors, but it's not by all.
Yeah. So do you think that it is applicable in every patient?
Not really. It depends on situation. If it's applicable, then every doctor will be doing it, in my opinion.
Okay, thank you.
Last questions? Audience? Ying, any questions?
Jaywin, I have a question.
Okay.
Can you explain to me or to the audience what is the right dominant circulation and what is the left dominant circulation?
Okay, basically, left dominance and right dominance is like your fingerprint. Everyone have different fingerprint, right? Not everyone, okay. How many of you are left-handed? How many of you are right-handed? So in the heart also the same. The heart also got left-handed, left circulatory major and the right major. So the circulation, I mean the coronary artery with more branches, they cover more on your left side and more towards your right side. This is called left dominance. And if the coronary artery cover more on your right side and more towards your left side, it is called right dominance. However, in the world population, there are only 10% are left dominant and 90% are the right dominance.
You showed a table with so many branches coming from the right and left. Which one of those would be the one in the right dominant circulation? And which one
The
would be
posterior, right posterior descending, or we call it the right posterior interventricular. Yeah, this one. This is the right posterior descending artery.
And in the left dominant circulation?
From the circumflex. Branching out from the circumflex and then it dominates the branches. Yeah. Did I answer your question?
Fine, yeah. There was another statement in the slide on restenosis. You said, can you go to slide on restenosis? Yeah, the second one, it said after a successful procedure, within in bracket you put 3 to 12 months, restenosis of stent thrombosis can occur. Now if you look at your case, the narrowing actually occurred after 2 days. So can you explain why?
8 years. 8 years.
Okay, so what you put there and 8 years is pretty long gap, isn't it?
Yeah.
No, I don't know why you put this statement. Is it from some reference, from some scientific material that you put that, or you just put it there?
I found it in the data in the Medscape.